Thank you, sir.
You will be given 5 minutes.
Okay. Uh, so, we have a debate between me and Dr. Subhajyoti, and I am in the favor telling about the fixed dose combination. Is that a boon for the primary care? So, before going into detail of the fixed dose combination, we have to know the definition. These are the medicines which contain two or more active pharmaceutical ingredients in single dosage forms. Generally, we are using different types of drug combination. Like for the antihypertensive, we are using telmisartan hydrochlorothiazide, telmisartan amlodipine. For the anti-diabetic drug, metformin, sitagliptin, and dapagliflozin, antibiotics, amoxicillin, clavulanic acid. And what are the purpose for the fixed dose combination? The fixed dose combination, it enhances the therapeutic efficacy and the patient compliances. So why it is relevant in primary care? Because it make the prescription simplified. It simplify the treatment regimens for the chronic disease. It improve medication adherence by reducing the pill burden. It's cost effective for patient due to single packaging and reduction in the hospitalization due to better disease control and also enhanced patient satisfaction and broad spectrum solution for infectious disease. So, what are the benefits? So, it improves the adherence, enhanced efficacy, reduced resistance risk, and lower the healthcare cost. So, this is a pentagonal framework of identified advantage of fixed dose combination. It is economical, it is safety and efficacious, it is system related, it's patient perspective, and the dosing is reduced. So different guidelines also says we have to initiate combination therapy. What ADA says, early combination therapy can considered in some individual at treatment initiation to extend the time of treatment failure. For people with type 2 diabetes and established ASCVD or indication of high ASCVD risk, heart failure or CKD, and SGLT2 inhibitors with demonstrated CVD benefit is recommended. Similarly, RSSDI also says considered initiating combination therapy if HbA1c is greater than 1.5 above the target. And for the age, for some recently diagnosed individual with type 2 diabetes and more severe hyperglycemia, unlikely to attain A1C target with a single agent, early combination pharmacotherapy should be considered, usually to include metformin plus another agent that does not causes hypoglycemia. So what is the approaches to rational combination therapy? Drug complement each other's action. Benefit 2 influences multiple target to optimize glycemic control. Benefit 3 preserve beta cell function to be effective over longer period of use. Benefit 4 matching dosing profiles makes use of simpler and easier. So fixed dose combination in management of type 2 diabetes, expert opinion from the international panel. They also tell about the same, that the triple fixed dose combination of metformin, sulfonylureas and voglibose targets fasting plasma glucose and postprandial glucose and thereby improves all 5 components of the glycemic pentads. And a multi-step approach is required to prevent authorization of irrational fixed dose combination. So we have to combine and conquer. Fixed dose combination in diabetes management. The majority of patients with type 2 diabetes do not achieve glycemic control recommended by leading diabetes organization using monotherapy alone or often require multiple anti-hyperglycemic agents to achieve glycemic control. Fixed dose combination therapies offer a means of simplify complex treatment regimens and have several advantages that help patients to reach their glycemic goals. Greater efficacy
Time is
compared,
over.
uh, for example, if we considered a patient with hypertension, dyslipidemia, obesity, and diabetes, and we are giving a fixed dose combination of DPP-4 inhibitor, SGLT2 inhibitors, and metformin. So we see that these combination of the three agent, they have a benefit on different parts. So potential benefits of early combination therapy in Indian type 2 diabetes. Benefit of early combination effective in providing good glycemic control. Combination of gliptin and metformin, it is weight neutral. Combination of gliptin SGLT2 inhibitors and gliptin SGLT2 inhibitors and metformin, there is weight loss. Early combination therapy shows durability in long-term glycemic control. Early combination therapy have lower risk of cardiovascular
Time
event.
is over.
Measures to promote rational fixed dose combination. Conclusion: fixed dose combination as a pragmatic solution for primary care physician to enhance patient care. They improve compliance, outcomes, and cost efficacy. Awareness and regulation are key to addressing associated risk. Medicine should always aim for simplicity without compromising safety. Thank you.
Thank you. So I'll invite Dr. Subjyoti Ghosh for he will be speaking on against the motion. And Dr. Subjyoti Ghosh is the diabetologist in Apollo Clinic, Dibrugarh. He is a member of RSSDI and other diabetes bodies. He is the president of Society of Study of Metabolic Syndrome and Diabetes. He has a various achievement and various presentation and publication in his pocket. Over to you.
Uh, Good evening, the House and the chairpersons. So I will be speaking about that FDC is not a boon for the primary care. So if you look, like your eyes are the best camera, and the camera can't capture eternity. Similarly, the FDC still is being used, but A1C is still high in India. So this is all about diabetes. It's a global epidemic. Everyone knows about it. Now, what's the current situation? We find that A1C of Indian status is still 8.6. And these are the drugs according to our DPCO. You can see the price benefit of the drugs under DPCO. Now the trends for the last 5 years of FDC. It suggested that approximately the market growth is 1.7 million US dollar 2024, which is going to increase by 2.09 billion by 2030. But the regulatory challenge is that the estimator suggested over 6,000 combination is available in India, where the concern have been raised about the rationality and safety. And if you look into the price variations, the combination of metformin and glimepiride 2 mg plus 1000 mg, it have a price variability of 15,958% variability in the price from lower to the highest. So this is about some studies showing about the FDC. We can clearly show that it highlights about the incidence of adverse drug effect was higher. And if we look about the one more study which has been reported about using of DAPA, SITA and metformin, just look in the sample size 274. So with this sort of studies, we are getting FDCs cleared in our country. And this is about a study showing about economic effect of fixed drugs combination versus loose dose combinations. The conclusion is that they are saying that it increases the disease-specific pharmaceutical spending in shorter term. This increase did not lead to difference in total healthcare cost from the payer perspective. So if we'll go in loose combinations, that will give us better. So this is again about the fallacies for approval in FDC. There is always a fight between regulatory oversight versus approval versus state. Then there is a lack of clinical evidence with insufficient trials. Market proliferation of unapproved FDCs are there. So why don't the physicians follow the clinical practical guideline? Because 76 articles across 120 different surveys have suggested that there are 293 potential barriers to the physicians to follow guideline adherence. So when I'm speaking about guidelines adherence, I'm again saying that my earlier speaker have said about early combination therapy. That early combination therapy doesn't mean that the fixed drugs combinations. It means like to accelerate the dose of initial drug, then you have to add the second drug. That's called early combination therapy. So that was what I was speaking about OAD in education. In our, we have like, we use oral drugs, but we, despite concurrent use, we don't go for the optimal dose before adding one more drug. So hence the FDC has proliferated in India. Now if we look after rampant use of FDC in India, what is the current status of A1C in India? It's still more than 9% in 29% of Indian population, and more than 50% where the A1C is between 7 to 9%. So with use of FDC also in India, still A1C is not under control. Hence, we are giving our patient a bad glycemic legacy to our patient. So what are the potential disadvantages? If we look, if we'll see in the era of precision medicine, we lack personalization while using FDCs. It increases the risk of side effect, which I've already shown in the slide. It increases the cost. There is risk of over medications. There is difficulty in dose adjustment. There is potential for drug interactions. Hence, the regulatory and quality concerns is always there. So now I put the ball to the house. Does the house still thinks FDC is a boon in primary care? Thank you.